So we'll get this started. So it's a pleasure to welcome Bob Gatenby, who's going to talk to us, give us his didactic, and he's going to talk about mathematical modeling in cancer therapy. And of course, many of you know that IMO wouldn't exist if Bob hadn't called me when I was in Dundee and asked me to come out.
Against me ever since.
And so that was quite a life-changing phone call. And that was way back in what, 2006, 2007?
Yeah.
But we had hatched these plans long before at a AACR meeting, right?
Yeah.
So it's always great to be able to introduce Bob because really has had such an impact on the science that we do in IMO, but also on this kind of evolving field of mathematical oncology when it's specifically talking about therapy. So I'm going to not steal any more of his time, but I'm going to let's hear from him.
Thank you.
Thanks.
Thank you. There talks today, I have to say, and I was constantly rewriting what my talk was going to be because I'm trying to sort of find interfaces where I can maybe make a comment or two. So this is going to be a little bit disjointed, and I apologize in advance. But everything I'm going to talk about is kind of summarized here. This is a perfect example of personalized medicine, target to drug to target matching. This is a woman with metastatic lung cancer. The EGFR mutation was documented on biopsy. She was treated with erlotinib. There are a number of other drugs that could be used and got a great response. Okay, sorry. And so this is really a triumph for personalized medicine. But the way this actually turned out is she continued to get erlotinib, and eventually she evolved resistance. And I'd like to propose that we are approaching a Darwinian era in oncology. And by that, I mean that when I started working at the Five States Cancer Centers a long time ago, there were just not enough drugs to treat. I mean, a lot of the standard cancers really had no effective therapies. And the remarkable drug development that has occurred in the last 3 decades has brought hundreds, if not thousands, of new drugs and new strategies into cancer therapy. And yet the mortality for metastatic cancers is generally unchanged. And I would say that increasingly the proximate cause of death in patients with cancer is evolution, evolution of resistance to a previously effective therapy. And I think that what we see here is that I would like to propose that just as personalized medicine should select targets, that we need to actively integrate our understanding of evolutionary dynamics into that second phase of this arc to try to either to prevent or at least delay onset of resistance with currently available drugs. This requires, I think, a change in the way we do clinical trials. This is just an example. It could be any number of them. But essentially, this very expensive trial, which lasted a very long time, at the end of the day, really just could say that drug A is better than drug B with some degree of certainty. What it cannot say, what it's not even ask, is why. And just sort of more generally, what are the underlying dynamics that led to the observed outcomes? And I think without constantly updating a framework of understanding, what happens is that these trials are then disjointed, that one does not flow into the other in a way that makes sense. And I think one of the reasons that we're doing a lot of drug development without necessarily increasing the cure or at least long-term control of cancer is that the way that we conduct clinical trials is I think inadequate. In particular, what is I think common in oncology is that progression is viewed as inevitable. It's simply an expected part of the outcome, and it's accepted fatalistically. I would propose that evolution-based therapy has to view progression as a failure and therefore unacceptable. And so I would argue that we need to both understand and act on the evolutionary dynamics that lead to that lead to progression and a drug failure. If you look at evolution, at cancer treatment as a game, it's a game between the oncologist who plays by applying a therapy and the cancer, which plays the game by evolving resistance. The oncologist has two major game theoretic advantages. One is it's a Stackelberg game. It was mentioned earlier, meaning that the cancer cannot play its move until the oncologist has applied a therapy. It's the equivalent of playing white pieces in chess. So in theory, the oncologist should always be out in front of the cancer. What I think is more important is that the oncologist is sentient. The oncologist can anticipate the future, that can anticipate the evolutionary dynamics of the cancer population, as opposed to the cancer itself. Evolving populations can only adapt to the here and now. They cannot anticipate the future. They cannot adapt to a treatment that they've never seen before. But here's cancer therapy in a nutshell. It's basically, as has been said before, the application of a drug or drug agents at maximum tolerated dose continuously until progression, and that produces this typical kind of U shape. So there's problems with this. One is that because the oncologist plays the same move at each cycle of therapy, the cancer simply evolves the same thing. You know, you select for resistance, you give the same therapy again the next time. The resistant populations are still there. They're just continuing to grow. Furthermore, you're ignoring what is in that middle there, where you have a very small population that's much less diverse than these larger populations. These are populations that are vulnerable to extinction, and yet these are also resistant to your therapy. So again, by continuing to apply the therapy, you're losing a potential advantage. And secondly, because the oncologist changes therapy only when the tumor is progressing, the oncologist has ceded control of the game to the tumor. The oncologist is now following the tumor rather than leading it. So everything I'll talk about now is really about getting the oncologist out in front of the tumor. Within this paper, we propose three game theoretic strategies to increase outcomes. One is to define the goal of therapy, cure or control. Although this would seem obvious, the problem is that if you have metastatic prostate cancer, for example, you can't cure it. It is not a cure. Historically, we know it is not a curable disease. And yet we treat with maximum tolerated dose, maximum dose density. We treat as though we're trying to cure, when in fact the goal is to control the tumor. The strategy, and we've talked a little bit about evolutionary strategies for cure, but it has to match the goal of the therapy, and it has to be an achievable goal. There should be a resistance management plan. We have to acknowledge that resistance will evolve inevitably, and that we need to understand and try to intervene with that. If you were a manufacturer that was making a pesticide, you were required by American law to file a resistance management plan, because in pesticides, it's well known that resistance, leads to progression, and yet none of this is done in cancer therapies. To me, it's remarkable that we don't really even understand the mechanisms of resistance to most treatment. And a third thing I think is to perform an after-action analysis. The military does this after battles. There's a variety of different ways it can do this. But again, this is the idea here is don't accept that evolutionary resistance is inevitable, that progression is inevitable. View that as something that can be changed, and look at what you've done to see what you could have done better. So again, you've all seen this. This doesn't really need to be gone over in great detail. Maximum tolerated dose therapy. And again, you start with a population that's mostly sensitive. There's a couple of resistant cells, and they're resistant either because of a priori some kind of genetic event, or they can become resistant very quickly. You give maximum tolerated dose, you get a really great response. But underneath that are small populations of cells that are resistant. And again, by continuing the same maximum tolerated dose therapy, you're essentially gaining nothing, and you're simply allowing the cancer cells to proliferate unopposed. And this is a well-known phenomenon. It's called competitive release. And frankly, if you look at the models for this, you could hardly do worse. And short of doing no treatment at all, this will actually tend to accelerate maximally the proliferation of resistant populations. Adaptive therapy is one of many strategies. There are multiple. So I don't want to say that this is the only one. But the goal here then is to rather than maximum tolerated dose therapy, you give actually the minimum necessary. So the idea is to explicitly retain a population of sensitive cells and use oscillations in that cell population to delay or proliferation of the resistant population. So essentially, you want to use the cells that you can control to suppress the proliferation of the cells you can't control. Now, I wanted to digress here slightly and just talk a little bit about what it means to be resistant. And I think our understanding of resistance is sort of incomplete. This is just a experiment we did looking at PC9, which is a lung cancer cell, EGFR mutation. You put erlotinib on it, and you can see in the top row here that you can very quickly get the T790M mutations, that pre-existing mutation rapidly growing. However, in the absence of cells with that mutation, you still get survivors. You can start with a dish of maybe 50,000 cells, so you might get 20, 30, very small number of survivors. And they will sit there for months, and then all of a sudden begin to proliferate about 3 or 4 months later. What's interesting is that this surviving population, both the ones that's stable and the one that's proliferating, is genetically identical to the PC9 mutation. There are no additional mutations. What we've learned is that, in fact, these cells are completely, at least initially, sensitive to erlotinib. What they are not sensitive to and what they're resistant to is the mechanism of cell death, the pyroptosis induced by the erlotinib. So my point is that although there's hundreds of cancer treatments, they all funnel through a relatively small number of death pathways. And so I think one of the dynamics that goes on here is that that proliferating cells transiently go through periods of time in which they are invulnerable or relatively invulnerable to cell the death pathways. I think we need to kind of understand that, and I think this is something that we need to focus on more, trying to understand why cancer cells survive therapy even when they are not technically resistant to the treatment. And I'll just, I should point out that what we found is that if we add the cytidine to these cells as they're evolving resistance to these epigenetic mechanisms, we can actually eliminate them. So this has, I think, the potential to develop new strategies where you follow up treatment with a specific treatment that targets the mechanisms of resistance. A second mechanism of resistance, which I think we've underestimated, is ecological resistance. This is neoadjuvant therapy in a breast cancer. That's the pre-treatment there, post-treatment on the right. What we see in these patients is not individual cells surviving, but small islands of cells surviving. And we can see that actually in both clinical samples and in preclinical samples, suggesting that there are ecological states which confer resistance for reasons that are not entirely clear. But what's interesting is that these cells are very metabolically stressed, high levels of HIF1 expression and GLUT1, which would suggest that these are actually vulnerable to things like anti-angiogenic agents. So again, this idea that if we can understand why they survive, we may be able to develop treatment options. And just as an advertisement, I think that one of the experimental methods that's been underappreciated is the window chamber. And what we're doing here is actually planting a tumor and watching the tumor respond to therapy in real time, to actually watch individual cells as well as groups of cells and regions emerge and regress during treatment. So back to the treatment. This is Jinsong showed this earlier today. This is a adaptive therapy using abiraterone. Just a little bit of expansion on this. There was a 28-month increase in overall survival in this group compared to the historic control. Patients did not receive any treatment at all about half the time. This resulted in a significant savings, $70,000 per patient per year. Some patients are still alive after a very long time. Again, this is all great, but the main thing I'd like to point out is the use of after-action analysis in this trial. So what happens is that we updated the model parameters using longitudinal data from the trial, and then we could apply the model to each patient so that we could, on an individual basis, understand what the evolutionary dynamics were that led to the observed outcome. More importantly, I think, is that we could then say, how could we have done it better? We could explore the parameter space and let the model show us how in that individual we could have gotten a better outcome. And what we found was that we made a mistake in the way that we designed this trial. The PSA was obtained every 4 weeks, and the PSA was the trigger for stopping therapy. When it got below 50% of the pretreatment value, we stopped. But what was written into the protocol was that had to be confirmed by CT scans. And we could get the PSA every month, but the CT scans were every 3 or 4 months. And as a result of that, we overtreated, that we would go for prolonged periods of time when the PSA was well below the 50% level, but we could not withdraw the therapy because the protocol required that we get a CT scan to confirm. So then we could say, well, suppose we had done this perfectly. Suppose at 50% PSA, we stopped therapy. What the model suggested was that there would have been a substantial improvement in the outcome. In fact, 270 months, a remarkably long period of time. And so one of the things I did is there's now a randomized trial going on in the Netherlands. I made sure that I called the investigators to tell them about this. Hopefully, they will not make the same mistake that we did. This is the second generation trial. This is a patient, again, Jinsong talked about this, androgen deprivation therapy plus abiraterone, and there could be a mixture. This is the addition of abiraterone to ADT is based on the Latitude trial, which was reported in New England Journal and Lancet. They had a median progression-free survival of 33 months. The median overall survival was 52 months. Since then, there have been other trials, probably the best outcome from primary therapy, whether it's ADT plus abiraterone or docetaxel, the number of ways that this can be done, is about 46 months. We've actually gotten to a point where we need 3 more patients to progress radiographically before we hit a median time to progression, but we know it cannot be less than 73 months. And so we're substantially over the best prior trials. And the patients receive no therapy at all, none at all, 57% of the time, meaning that their testosterone level is normal more than half the time, which greatly reduces the toxicity associated with androgen deprivation therapy. They're actually getting both drugs only 12% of the time. Again, abiraterone is very expensive, and so this is a significant reduction in cost. This is not necessarily surprising. Since this all started, I have patients that report to me about how they're doing. We actually have 2 patients here. One is a PhD engineer and one is a lawyer, and you can probably tell from the graphs which is which. But they both are treating themselves with cycled androgen deprivation therapy, basically adaptive therapy with androgen deprivation therapy alone. And both of them remain stably cycling after 13 years. The patient on the above graph had a Gleason 9. They also continue to have metastatic disease because their PSA goes up very rapidly when they stop therapy, and yet they remain stable for very prolonged periods of time. And again, what we've done with after action analysis, even though the trial has not reached median time to progression and is not yet reportable, what we have done is analyze the early progressors. What did we do? How could we have done it better with them? One of the things that we found here is that in addition to the PSA measurements that we obtained, we were simultaneously getting testosterone. And it turns out that second data stream was very important. What we found, and Jill is the modeler who's looked at this, is that the PSA to testosterone ratio was an excellent biomarker. As the PSA to testosterone ratio went up, the probability of progression went up. What we assume then is that increase in the PSA reflects a resistant population that is using that can proliferate at castrate levels of testosterone. What it told us is that our initial model was wrong. We had assumed that what we call the T-minus population, the resistant population, was completely independent of testosterone. What we've realized now is that, in fact, these are typically hyperexpressing androgen receptor cells, and therefore are simply proliferating, receiving a proliferative signal at castrate levels of testosterone. And so this actually provided us with a potential treatment strategy. And this was, I think this was alluded to earlier today, that one of the things that's been found is that androgen, prostate cancer cells that are hyperexpressing of androgen receptors are vulnerable to sudden increases in testosterone. When you at physiological or supraphysiological levels, they get this hyperstimulatory state, which results in androgen, which results in apoptosis. And so this gave us an idea. Could we use directed evolution to restore castrate sensitivity in patients that had castrate-resistant disease? Now, just briefly, the idea then is that if we were injecting testosterone, you would get a sudden increase in testosterone. The androgen, the resistant cells that are hyper-expressing androgen receptors will die. And the cells that are normally expressing androgen receptors will proliferate, but they're the guys that we want. So the goal here was to invert the population distribution to restore the cells with normal androgen receptor levels, so that we could restore castrate sensitivity. We could restore response to androgen deprivation therapy. So this is a patient who had an unusual situation. He had, because he had congenital peripheral neuropathy, he had congenital osteoporosis. He was unable to tolerate either abiraterone or really any of the drugs that are typically used in a castrate-resistant disease. And so he was cycling on ADT, but clearly progressing. And since there were no other options in this patient, we felt that we could, with of course informed consent, try this directed evolution. And so what we did was we gave him 4 injections of testosterone. You could see the sudden increase in testosterone. The blue is the PSA. And notice after the first injection, so we're going left to right, he's progressing. First injection, notice a really big upswing of PSA. Went down. Second injection, a much lower uptick of PSA. The way we interpret this is that we're seeing the response from both the androgen receptor hyperexpressing cells and just the regular androgen receptor cells. And at the second cycle, because the PSA is much lower, we have killed off a significant a fraction of the resistant population. And then you see that in the third, and then between the third and fourth cycle, the PSA went up a little bit. And so what we think at that point was that we had selected for the population that we want, and we had restored gastric sensitivity. And you can see that since then, these 3 cycles of ADT, and it's dramatic reduction of the PSA, I think indicating that we had restored the population that we want. This gives us a potential game plan of cycles. If we can maintain the castrate-sensitive state for prolonged periods of time by using adaptive androgen deprivation therapy plus minus abiraterone plus minus some other drugs, and we can push the patients back to the beginning using this conversion technique, we could now have, again, cycles within cycles to the point that we could, I think we have the potential to convert metastatic prostate cancer to a chronic disease and essentially eliminate deaths related to it. With that, everyone, I would particularly like to recognize Bob Gillies and Tom Vincent, two very important people that have contributed to this, and both of whom have passed away, and would like to remember them today. So thank you.
Where's that?
Mike, there.
Hey, Bob, it's so beautiful to see these many years of work in such a nice presentation. So congratulations on all that. So it's the first time I've seen this latest work of testosterone injection, which is really exciting. And you make the claim that you can resensitize these cells to ADT. Do you foresee an opportunity to actually go for extinction in this scenario rather than your intermittent cycling? Do you think you can get them so resensitized that they can go for cure?
Yes, I mean, I think I think the extinction strategy is probably the only one that's going to cure cancer. I don't know that we have the right drugs or the right agents for that yet. We have an extinction trial that has completed accrual, and so we will see that, but it's not in this kind of setting. And as we learn more and more, I think we'll probably get better and better at defining the multiple hits that you need for extinction.
Yeah, so what I've seen now is you start injecting testosterone after you get ADT progression on wild cycling. Could you give testosterone up front, anticipating this and say like, hey, you know what? It would change your intended strategy from control to cure.
Absolutely. I mean, I think that we, so androgen, just to be clear, injection of testosterone in men with metastatic prostate cancer is not unprecedented. BAT therapy, which was alluded to before, has shown that you can do that and you can do it successfully. I think that I think your idea would be to totally eliminate the resistant population first, and then attack the dominant population that's and I we think alike. That's a good creative idea. We could try it with animals and see. So okay.
Yeah, that was really fascinating. I wanted to ask you, if you're trying to restore the sensitivity, how much does that ability depend on how resistant the tumor already is? So if you have a patient who's kind of failed multiple lines of treatment, is it possible they're so overrun that it's not possible, or can you kind of bring it back?
Yes, absolutely. And so one of the things I think happens is that resistance that's epigenetically obtained will become hardwired genetically over time. And so I think that in this setting, I suspect that the androgen receptor hyperexpression will yield to just independent growth of testosterone over time. So I think that we have a real opportunity to do this as the patient is progressing. I think that the probability of a successful outcome gets smaller and smaller over time after that. Now we have money for a clinical trial. So we're going to look at this, and that's one of the things we want to look at is patients as they are actually the patients in our ADT trial are now going to be offered the opportunity to get testosterone injections when they progress. And then we'll also get a group of patients who have had castrate resistance for some period of time and see if we can get the same kind of outcome. My guess is we will be successful in one and not the other. In the trial that we're talking about now, where we want to essentially do a randomized trial where the goal is to eliminate progression, is that we'll have this similar to what we have here, androgen deprivation therapy, adaptive, and then they will at least have the opportunity to get testosterone injections at the time of progression so we can shoot them back.
I was really curious, in the patient time course that you were just showing, there was sometimes when Orgovyx was being given and testosterone was being injected simultaneously. So what do you think is happening when you have kind of double selective pressures going on?
That is this one?
Yes. So I was specifically thinking about, yeah, the kind of that first testosterone injection is at kind of the beginning of the Orgovyx period.
Yeah. So Orgovyx will, correct if I'm wrong, it blocks the effects of testosterone. It reduces testosterone. Okay. Okay. Right. Yeah. Yeah. So what we didn't want is to have native testosterone going up and the injected one going up. Now I don't know that that's. Let me back up a little bit. The problem with the adaptive cycling is that over time the testosterone level does not go up really quickly. It tends to lag behind, and so this I think was alluded to in one of the previous talks. The longer it's in this low level, the more we're selecting for the resistant population. So we don't want that. What we want is a very quick upturn, and so using the patient's native testosterone may end up not being how we do this. But yes, and the goal here was to just rely on the external testosterone so that we had better control of it. Sure.
Yeah, no, I agree that we wanted to keep complete control of the patient's testosterone level. So with our injections, so by giving the Orgovyx prevents centrally through the brain testicular stimulation and testicular production of testosterone. So we can get the testosterone level down to 0, which you do see. We are able to do that there, and that was the reason for continuing the Orgovyx during the testosterone injection.
Very sluggish increased testosterone, which I think is going to be a long-term problem. And one of the many variables that we need to consider in this is like these nitty-gritty details that I think are important.
Okay, let's thank Bob again for a very nice presentation.